Okay. So given all of what we've talked about with etiology, you could probably make some good guesses about what treatment's going to look like. In that last slide, I don't think I said it in the lecture, but I asked you to look at psychological treatments, and we'll talk a little bit about how psychological treatment can be supportive and helpful with schizophrenia, but psychological treatment is simply not going to manage schizophrenia by itself. That's such a largely biological and a largely heritable disorder. The treatment is going to have to address those things, and that's going to be pharmaceutical treatment. And so it really does focus on medication. We have antipsychotics, phenothiazines. The original one was thorazine, which is our oldest medication that was used for schizophrenia, and similar medications that are grouped together to be called phenothiazines were the original medications that were used. They are very, very good at treating positive symptoms in most people with schizophrenia. However, they have a side effect called tardive dyskinesia, where you develop uncontrollable movement, and the movement problem focuses on the face. There can be other uncontrolled movement, but the face, and so you might get grimacing or tongue thrusting, other face movements like that. And once it starts, it is a side effect that's permanent. Even if you discontinue the medication, the side effect continues. So it's a really disruptive and really sad side effect. And so once upon a time, when we first started using thorazine, we didn't know that that was the case. We would use thorazine at high levels. We got better then, knowing that the side effect is starting at low doses and watching carefully for side effects. Not everybody develops them. But it does a good job of treating positive symptoms. It does not, these medications do not do a good job of treating negative symptoms. And so people with mostly negative symptoms, or even if they're experiencing some negative symptoms, would often continue having symptoms and continue to suffer in this way. And then we developed this secondary, I'm going to move my face here, we developed second generation medications that are much better at treating negative symptoms. And the difference between these first generation medications really are acting primarily on the mesolimbic system, right? So they're not acting on the frontal lobe disruptions to dopamine. The other way of understanding tardive dyskinesia is dopamine, you may remember from Psych 111, is very involved in, it's an inhibitory neurotransmitter on movement, on voluntary movement. And so if we drop the levels of dopamine, it helps in the mesolimbic system, but also then deprives those neurons that rely on it to inhibit movement, and then we get this uninhibited, uncontrolled movement. The second generation drugs do a better job of acting on the dopamine disruptions in the frontal lobe, which is why they are better at helping with those negative symptoms. I didn't realize that was the last slide, guys. In addition to these, right, so medication is a bottom line first level treatment. It has to be there to treat schizophrenia. But in addition, people with schizophrenia may have a therapist that would be in part for social support purposes, but also it may be to help manage home environments that maybe make it more likely that you might have a relapse of symptoms. We talked earlier in the semester about expressed emotion, and that if you're living in a household with lots of expressed emotion, the risk of relapse, the risk of onset of symptoms despite medication is higher. And so managing family dynamics, making decisions on how you engage in family dynamics might be part of it, but just also making decisions about what you do in other aspects of your life that might help avoid an onset of symptoms. So we're going to end there. Obviously, in our live discussions, we'll talk more about all of these things.